Hi everyone, my name is Mabel Toribio, and today I'm going to be speaking about hot flashes and cardiovascular disease risk indices among women with HIV. Now, as many of you know, hot flashes is a very common symptom during the menopausal transition, and in the general population, hot flashes relates to both increased inflammation as well as decreased blood vessel function. And both of these parameters have been shown to predict cardiovascular disease or heart disease events in the general population. There's also been several studies among women with HIV that have found that they have an increased risk of heart disease, including both heart attacks as well as heart failure. And so my graph here on the left summarizes results from a study by Triant et al., which demonstrated that women with HIV have a threefold higher risk of heart attacks compared to women without HIV. Analogously, there has also been a study looking at heart failure risk among women with HIV by Chant et al., which recently found that women with HIV have a 3.67-fold increased risk for heart failure compared to women without HIV. Additionally, there's also been at least one prior study which has demonstrated that women with HIV also have an increased frequency as well as severity of hot flashes. And here are some of the key results shown in this study by Luby et al. Now, derived from these prior research findings, our study team had two questions that we wanted to address. The first was, what is the relationship between hot flashes and immune activation inflammation among women with HIV? Secondly, we also wanted to address what is the relationship between hot flashes and subclinical heart disease among women with HIV. In order to answer these questions, we leveraged a prospective cross-sectional study that enrolled 23 women with HIV and 19 women without HIV who were group matched based upon age and body mass index. These women underwent a detailed reproductive health history interview. They also had laboratory assessments to assess levels of immune activation and inflammation. And lastly, they had cardiovascular imaging in the form of a magnetic resonance image, or MRI, and MR spectroscopy, or MRS. We enrolled women between the ages of 40 to 75, and for the women with HIV, they had to be stably on antiretroviral therapy for several months prior to enrollment. We excluded women who had a history of cardiovascular disease or heart disease or a history of diabetes. And so this table here summarizes our baseline demographic characteristics of our study cohort. As you can see here, the two groups enrolled had very similar ages as well as body mass index, and this was by design. Further, we were able to enroll a study cohort that was relatively diverse in terms of race and ethnicity. Further down in the table, you'll see that the women with HIV had higher levels of select markers of immune activation inflammation, including soluble CD14, which I'll discuss in more detail in one of the following slides. And then lastly, you'll see here that the mean year since HIV diagnosis for the women with HIV was around 19 years, and that the women with HIV were mostly virally suppressed on their antiretroviral therapy. Our second table here summarizes our reproductive health assessment results. And what you'll see here is that there were no between group differences in terms of the percentage of women who had an absence of a menstrual cycle within the past year, as well as the percentage of women with an undetectable anti-Müllerian hormone, which is a marker of ovarian reserve. Additionally, none of our study participants were on any estrogen or progesterone therapy currently. And then lastly, and most importantly, we found that the women with HIV has a significantly higher number of days per week where they reported having hot flashes, with the median being 7 days per week within the women with HIV and less than 1 day per week among the women without HIV. And so these results, which demonstrate a higher hot flash frequency among the women with HIV, are consistent with that of the study by Luby et al. That I previously described. Further, we also performed sensitivity analyses excluding either women who had a menstrual cycle within the last year or women who had a detectable anti-Müllerian hormone, and found that among these sensitivity analyses, the women with HIV still reported a higher number of days per week with hot flashes. Additionally, among the women with HIV who had experienced a hot flash within the past year, they reported also having a longer duration of antiretroviral therapy use. So moving on to the questions that we wanted to answer with this analysis. So the first one, as a reminder, was what is the relationship between hot flashes and immune activation inflammation among women with HIV? And so as a way of background, we were able to assess several markers of immune activation inflammation in the bloodstream in the women in this cohort. And one such marker that we assessed is known as soluble CD14. And the way that we're able to assess this marker is that CD14 sits on the surface of an immune cell called monocyte. And when monocytes are activated, they then cleave the CD14 from the surface of the cell, leading to the formation of soluble CD14, which we can measure in the bloodstream and circulation. And soluble CD14 levels have actually been associated both with mortality as well as heart disease progression among people with HIV. So it's a very important marker of immune activation in terms of people with HIV. Now, in our particular study, among the whole cohort, as well as among the women with HIV, but not among the women without HIV, we found that women who had more than one hot flash per day actually had higher levels of this marker of systemic marker of monocyte activation, soluble CD14. Now, moving on to our second question, which was what is the relationship between the frequency of hot flashes and subclinical heart disease among women with HIV? In order to assess this question, we performed a very unique imaging modality known as cardiovascular MR spectroscopy. And this imaging modality allows us to quantify and measure the amount of heart muscle fat content, known as intramyocardial lipid content. And there's been both animal studies as well as general population-based studies that have shown that an increased fat content within the heart muscle tissue results in diastolic dysfunction, which is a form of impaired cardiac function that is an important intermediary to the development of heart failure. Now, among our women with HIV in our study, we found that the years of onset of hot flashes the years since onset of hot flashes related directly to an increase in the heart muscle fat content. Further, we also found a significant inverse relationship between the years since onset of hot flashes and diastolic function, such that the longer the duration that these women had experienced hot flashes, the worse their cardiac function. And so with these findings, we were able to conclude indeed that there were key relationships between hot flash frequency as well as immune activation inflammation and cardiac pathology. However, our study was limited by a variety of different factors. One of them was that we had a small sample size and recruited women from one geographic region, which was the greater Boston area. We also had a cross-sectional study design, which precludes inferences related to causality. The women in our study were not matched based upon their reproductive aging status. Further, we also were not able to assess for the effects of older antiretroviral therapies on hot flash symptomatology. And then lastly, our ascertainment of reproductive health history was based on interview and so therefore may have been affected by recall bias. Despite these limitations, our study was strengthened by the racial and ethnic diversity of our study population, which reflects that of the women with HIV in the United States. Additionally, we performed detailed reproductive health history as well as assessments through our measurement of the anti-Müllerian hormone, or AMH, which is a marker of ovarian reserve. And lastly, our study included a detailed immunophenotypic data as well as metabolic and cardiovascular phenotypic data, which we analyzed together with our reproductive health assessments. So just to summarize, our study found that indeed women with HIV did have an increase in frequency in terms of hot flashes. Further, we found a relationship between hot flash frequency and a marker of systemic immune activation in people with HIV that has been shown to be related to both mortality as well as heart disease progression. Additionally, we found that the years since onset of hot flashes related directly to heart as to heart muscle fat content and inversely with cardiac function, specifically diastolic function. Now, what remains to be determined is whether or not this hot flash symptomatology among women with HIV directly contributes to the increased cardiovascular disease risk that we see in this population. And we hope that studies in the future may address this and answer this particular question. And now, in summary, I'd like to thank the study participants who volunteered for this important research. Additionally, I'd like to thank the study team members who were responsible for the conduct of the study as well as this analysis. And then lastly, I'd like to thank the Center for AIDS Research at Harvard University, which funded this research project. And also thank you for your attention.